Hello and welcome. This is recording about all the skills that the ANC is assessing, and the examiner is looking at how you perform during your examination. It's all taken from the AMC Handbook, and there is a reference page. The page might be of the electronic version, not the physical book, but you will be able to find it. I'm sure of that. And I don't know what you think, but in my experience, I find really hard to understand how the handbook is made and the order. So I try to break it into ways that I could digest the information. You will see here that they repeat a lot of stuff. However, the most you listen to it and you get it from different points, it will stay in your mind and you will assimilate and use it for your benefit. So we're going to start by looking at all the communication skills, which is something that is assessed throughout all the consultation and your exam in each stations. So the ideas may not be in order, but all are important. So focus and listen. We are being assessed on how we talk, the bedside manners that we show. We are doing all online examination at the moment, so things change, but we can adjust to that. History taking is a big part, and you will see here that there's two approaches. We always recommend to first go deep and ask the patient to talk, and we listen. So all the open-ended questions will help to gather more information that we need for the next part of the consultation. So listen without interrupting, allow pauses, and just facilitate dialogue. It's important for us to know that most of the doctors sitting the exam, we don't have English as our first language. So it's important to talk clearly, slowly, and to make sure that you understand what the patient is saying, so you can clarify, and the patient understands also what you are saying. So it's all about as well empathy, consideration, non-verbal communication, what's happening with the patient, explaining in simple terms with no technical language when you're talking to the patient, and be professional when you speak directly to the examiner if you are requesting information or answering a task directly to them. The history, there will be scenarios and stations when they allow you to request a lot of information and focus on history, like say 5 minutes, focus on history. However, others, history is just a little part of the case, and they want you to do 2 minutes in the station about the history taking. So you need to organize your mind, and that's part of the planning stage, looking at the tasks where you're going to focus more and how much you can go deeper and ask there. Commenting to the examiner, you will need to talk about the physical examination findings now that we are not examining the patients ourselves. So you will have to be clever and to practice a lot how you're going to request for those findings, what findings do you need to ask, and also when you do the differentials or you present a case summary to the examiner in the best way that you can prepare and express yourself. So it's all about the listening, using facilitator prompts to make sure the patient starts to open and give us the clues and the information that we need to move into the next step, and to, of course, to get the diagnosis right and be able to help them. So first the open-ended questions, and then go more to direct questions and closed questions, so you can control the time and clarify also what you are looking for, because you need to gain the control towards the end of the history. We will cover this in the next workshop about history taking, but it's all about understanding clearly what is the history of the presenting complaint. There's also important to not leave apart a quick scan, what else is going on in the patient's life and different areas. So do the system review, and of course, just check the general health. Depending on the scenario, you will need to ask some questions. They are not relevant for others. And as I say, it all depends on how much time you need and you have available to complete the task. So always start like, how can I help you today? Tell me more about this. I see that. What else is being going on? And then just clarify with the close questions about the symptom, or if you are missing something else. The same, describing the differentials is all about how you communicate to the examiner or to the patient, being clear, explaining the condition. The same with the management plan. This is not an exam that is testing you and evaluating how much you know about the management. Prescribing is all about the big picture, getting to a diagnosis and helping the patient move into the next step. Counseling, getting information, or organizing the next, referral or investigations. The same, how you explain a procedure, or yes, talk to someone, a family member, if the patient had an accident or is in surgery. And of course, the patient, sometimes the examiner will ask some questions that you need to be ready to answer. All the domains, if you see, are looking at how you talk, and the examiner is assessing you in different ways. So the communication skill also includes the trust, the confidence, the empathy, the rapport, how you make the patient feel, and all the understanding that facilitate your consultation. Next one is diagnosis formulation, and for that, you need to get the history and of course have a clear physical signs, what's happening during the examination. You're framing the problem, you're trying to understand and look for questions that will help you get to the answer. So you summarize the events, you have a hypothesis, and that's when you have a list of differentials. So all that reasoning that is happening in your mind, this is a image from the book, will get you to hypothesis, and then you will exclude things because of some findings. You can move towards something, and then with investigations or more information, you will be able to get to the diagnosis and then start the management. So it's more about not missing, of course, any emergency life-threatening conditions, and making sure that you have in your list 3 or 4 diagnoses that could be related to the presenting complaint. So physical examination, we are not doing that now with all the changes to online format. However, don't forget that it's all about the looking and inspecting first, feeling, listening, measuring, comparing, moving if there's yes, extremity or area that you need to measure, if there's any, like the function. The most important is to focus and follow an order. The examiner doesn't want you to be jumping from history to requesting findings and examining one thing and going back to inspection at the end. So focus on an order, and the more you practice, you can do this best. I have a lot of resources within my full clinical summaries that I offer, and they have the audio scripts of the sequence of examination and also for physical examination findings, and that helps you. The more you listen to the audios, the more it stays with you. So it depends the same what you need to do. If it's full examination for someone that has fever for a long time, or if it's someone who broke the elbow and it's a focal examination. So it depends what the task you are asked for and how you're going to get the information. So if you are the patient, if you have the patient in the room, it's all about gaining consent first. Remember to wash the hands, avoid causing any discomfort, and ask the patient to ask openly, please let me know if this hurts, we will stop. Check first, as I say, the inspection. And also for the online summary, it's all about talking to the examiner and finding what the patient has. So the same, having the clear order in mind. Here, the physical examination stations could be 5 or 10 minutes. And depending on that, you will have either 1 or 2 minutes of reading time before you start. So with having some kind of differentials in mind, you will focus your examination in getting some or other signs, but the same. This is what we said before, what we all do when we are with a patient in the room. So what's happening next? We have some ideas, differentials, and it's most likely that we don't have a diagnosis after a short consultation. It's always looking for more investigations and ways that we can understand what's happening. So how much diagnosis test do you really need? If you want to ask a lot of tests, it tells the examiner that you have no idea what's happening and you need to ask for everything to rule out things. But the more you understand the condition, the more focused you will be on the investigations that you want. So this is just general stuff about the sensitivity and specificity of a test and the utility. So with the focus on the history and exam that we have done, the same, check exactly what do you need to do. Do you really need to get a test? And what is the test that, if you have an answer for that, how can that clear the situation and help you to gain to the next step of the diagnosis? This section is really interesting and covers all general consultation. So you can also find it in this page 322 and explains in detail everything that needs to happen as a professional interaction for a patient with a doctor. And the same, focus all in the relationship, communications, how you make the patient feel, how much rapport you build, and how is your clinical reasoning, of course, to define the problem and identify the signs and interpret the investigations if you get results. So it's all about getting the first part of the management plan done and getting the patient to agree, getting education and counseling on what's happening. So here are some errors that patients that the doctors made, and is ignoring that non-verbal communication, and I said, not establishing good rapport, the use of jargon or things that the patient don't understand, or just, yes, broken communication, narrowing the focus to some. So that's why we want to start with the open questions, and that gives you an idea what the examiner is wanted to check. No, always you need to know who you are, and that will make things totally different. So by setting the scene, if you are the GP or if you are emergency, if you are a doctor in the hospital ward, it will all change what you can do, the resources that you have, and who you need to discuss the patient with, your superior. So keep that in mind. The safety, the privacy, dignity, that's very important here in Australia. So make sure the patient is happy with you in your interactions. And the same, we have probably mentioned this, but it is important. So we go again, being empathic, non-judgment, but just open to listen, making eye contact as much as you can, and reflecting that you understand what's happening. The same. That's why I say that the history taking is one of the most important skills, because we are detectives and we can get to the top differentials with the good questions, and just by allowing the patient to talk and to guide them with the questions at the end. So it's very important that we have that in mind. And of course, the clinical examination and the findings that you request for the examiner has to be, you have to be clever what you request in your little time that you have to get you to the diagnosis. And as I mentioned, investigations shouldn't be your top priority or the focus, but it's just a small amount of tests, and they only contribute to 10% of the diagnosis in the cases. Medical history, the same. We start with the basic information and understanding what's happening with the presenting complaint. Then we also ask about past medical history, the medications, allergies, and habits, do the relevant system review, and check on family history, social history, and mental health history. So when we move to the clinical management and we have formulated a plan, it's important that we include education and reassurance with the patient, giving advice and the information that is right at that moment without overwhelming the patient, prescribing medication if we need to, or recommending a test, a procedure, a referral, admitting the patient to hospital or referring patient to hospital, and always the follow-up and talk to whoever needs to be involved in the case for the patient's best interest. So management, as I say, we don't want to do a full deep explanation, but it's more about telling the diagnosis in simple terms, understanding that the patient knows what's happening and how severe or serious it is, and also educating about the condition. Always allow time, or just mention, do you have any questions? Leave the opportunity to let them know that you care, that patient is also understanding what's happening, and to engage in a dialogue. So you can propose the therapy and just explain why you are doing it and what's the next step. Always they like to have a follow-up time frame, so you know patient is not left alone, but is actually engaged in the system. Therapeutics is not much. The cases, scenarios, and the stations, not many. However, you need to know how to prescribe. There's some great resources. And also, I have those in my full clinical summaries if you want more information. So yes, as I say, history is one of the best and the most important parts that you need to work out. How you're doing it. The same for the drug users. Keep in mind, of course, pregnancy, children, elderly patients will need to have a smaller doses. But of course, if someone has a liver failure or renal insufficiency, but as I say, it's not many cases. However, you need to be aware who you are talking to. This is a list of the most common prescribed drugs here in Australia, and some of the drugs that patients may say that they are using at the moment when you ask about medications. So this part is more about clinical perspectives and how to organize priorities, always with the patient in mind. So yes, it's all a skill that the more you practice medicine, the better you get at. But it's all about making sure that you take the right steps that the patient needs to have more cost-effective treatment. And of course, all the communication is there. So it also shows that you have a knowledge of the underlying anatomy and physiology. You have all the training, you have all the experience, you believe the skills that you have, and you are just here presenting and talking. So the best way you talk, it will show you how much you know. But of course, if someone is coming for abdominal pain with signs of peritonitis, it depends, like, you know what's happening, you know it's an emergency, you can then make a diagnosis, and by the side of the pain, you will keep that in mind and the formulation of what's happening. So it's all the timing and how accurate you are with your knowledge. There's a lot of examples, and I have here the pages where they are listed. So yes, it's all about discussing and how you talk to the patient to help them understand what's going on. Emergencies and serious conditions that require management. So it's testing your ability to know when the patient is severely ill and you need to act quickly, refer, or look for help. Even if there's no diagnosis, it's more about starting the management first. So you need to recognize cardiac emergencies and how they present, respiratory emergencies, like yes, of course, asphyxiation or a pneumothorax that needs to be sorted straight away, circulatory emergencies, if a person is in shock, of course, a patient that is not alert and doesn't respond, sepsis, and also in pregnancies, there are some problems that need to be taken as soon as possible and prepared. And of course, it's all about a teamwork and you are not alone. It's just getting patient to be helped by all the medical team. Same emergencies for severe trauma. And if there's poisoning, there's some cases as well in the exam about the snake bites, for example. So to finalize, this is more about the ethical and legal dilemmas. There's a lot of information and you will be able to read at your pace these downloads of the slides, but it's more about making sure that you understand the law and you know how much you can do or say, and the responsibilities for doctors and also for patients. So it's all about professional skills and the ethical principles, the autonomy. The patient here has a lot of autonomy that doesn't happen in a lot of overseas places where we come from, but here the patient is always right, pretty much. So the patient needs to be informed, the patient needs to get consent for everything. And also, yes, don't expect to have the information and the right answers all the time, but it's more about recognize what's happening and also look for assistance or seek help somewhere else. So you need to know where to find help if something is happening. You need to know that you cannot be prescribing medical certificates to anyone who comes to ask for it. When you're talking to teenagers, you need to know if they are able to consent and to go ahead if they understand what's happening. The same if you are talking with sexual assaulted, rape cases, it's important that there's always clear explanation about the confidentiality statement and that you will disclose information if they are in danger or you need to take things to court. We need to notify diseases as we all do in different countries. So it's more about by law what you need to notify and how you do that. As I mentioned, confidentiality. Drug addiction, that's a big thing here, how you prescribe medication and the control that you need to have with patients that need to come daily instead of prescribing a pack of 30 medications, medical fraud, all the support that you can find within your profession, and it's all the system. So there's a lot of medical legal. However, the cases is more common sense once you have an understanding. So just read the chapter to gain more knowledge about it and become familiar with what to expect. To finalize, these are some instructions that are listed as part of a trial examination. And it's always to remember all the tasks, you get tasks from the start. In the online format, you will have tasks available at all times together with the clinical notes. And is reading carefully. Sometimes we miss the information because we scan too quickly and we exactly don't know what we are reading. So read carefully the notes and always read what they are asking you to do, because if you perform really well and you treat the patient very nicely, but you don't answer the tasks, you're still going to fail the station. The same, if it's focus history, don't spend 5 minutes, but just gather the most important things that you need to move on to the next task. So these are all role-playing patients, so maybe real, but still you need to behave and act as they were patients, and they are only going to talk to you or to respond depending how you ask the questions. They have a script as well in mind. So it's important that you do your best to be able to gather the information with the appropriate questions. The same, if you are doing a focus examination, you cannot examine the patient from head to toe, but just focus on the system or in the area. And the same, talking to the examiner to gain the findings and to then explain the case. It's all about the communication, the time management. So physical examination indicate what you are actually looking for, not be very random, vague when the examiner when you're talking to the examiner about the findings, but request what you're looking for and what you expect to see, considering the history that you have already collected. The same for the previous examinations or investigations, additional tests that may be available. Request exactly what you are looking for. We already discussed about that, keeping the language plain and simple when you talk to the patient, and respond to questions if the examiner asks. So always be clear, concise, and remember that the patient is listening to all the interactions that you have with the examiner. So final things to keep in mind, try to keep things as simple as possible, work on getting excellent at time management, speak clear, slowly, so your English is easily understood, follow the tasks in the order that they are, and use the simple language. Keep the patient happy, and just smile and do your best. Thank you for listening. This is the first of 4 series of workshops that we are covering, and it's pretty much the same information, but we will get more in detail about the history, physical examination, diagnosis formulation, and then the clinical reassurance, education, and counseling. There's more information. I have great resources that have helped me a lot to prepare and pass the exam on my first sit after 14 years of no practice, and they have helped many other doctors who like how I compile, explain, and classify the information, because there's a lot. It's more about how you use it without getting lost. So if you like this, keep going to the next, and remember there's more in my full clinical summaries. Thank you for watching. Bye.